This project was envisioned to connect several of my interests: social determinants of health, health equity, and bioinformatics. I provide hormone replacement therapy and see a large volume of trans patients, representing a convenient sample of a patient population with significant health access issues that especially pertain to vigilance and perception. One of my observations has been a high rate of patients who initially establish care with white coat syndrome and anxiety that's obviously, if not explicitly, stated as due to seeking care. This is a well-characterized source of anxiety for trans people. I've also been interested in learning more about clinic-based research and many aspects of clinic experience that can be subtle for patients and providers and difficult to assess directly. The significant hurdles involved in directly surveying patients and doing so en masse may hinder the identification of worthwhile areas to focus on in trying to improve patient access and experience, especially for marginalized populations. We have a growing body of knowledge, as I outline here, that may render the health impact of stress and anxiety more intelligible and actionable. If certain kinds of stress have disproportionate impact through the minority stress model, this would help explain inconsistency in trying to understand white coat hypertension and what this finding means for a patient's health. The challenge in trying to develop a biometric indicator, of course, is ensuring that it's not more trouble than it's worth. My hope in designing this study was to make data collection simple enough that it would be trivial to repeat and adapt in subsequent cycles, and that this would identify areas of the patient experience worth further studies and improvement. Unfortunately, this was not the case. Some of the issues, as I outlined, were transient and related to academic scheduling and staffing issues. But the potential for significant and unpredictable variation in aspects of rooming and care not tracked by EHR suggests that a larger sample would not produce meaningful data or be practical for sustained implementation or future adaptation of this protocol. In hindsight, I also feel that the known and demonstrated variations in BP and heart rate for countless unrelated and semi-related reasons present an insurmountable signal-to-noise issue for a single provider or clinic studying a single patient population. Reflecting on this, I suspect that if vitals can be used to detect issues with patient experience, the most likely successful approach would involve very wide-scale machine learning analysis of thousands or tens of thousands of patient encounters. Ultimately, this study was a negative result, but did provide valuable experience in designing and implementing trials in an outpatient setting that will help inform future proposals.